Hi friends, welcome back. So several times you have heard alcohol consumption and smoking can result in the development of so many diseases, especially cancers. So alcoholism is one of the risk factors for the development of cancers. So why anytime have you think about why alcohol consumption result in the development of such diseases? And one more thing, have you heard about the term Xanthopsia? So once again, welcome you all back to our channel, the Nurse channel, and today we will be discussing another 15 questions, important, very important, informative questions, which will be helpful for you for the preparation for your SCT, JIPMER, NORCET examinations and the upcoming ESIC examinations. Okay, so you all know that we are in our SCT series, and already we have uploaded so many videos, nearly 5 videos, 5 series we have already uploaded, and this is the next series, and this series also contains 16 questions. And I request everyone who are watching this video kindly watch till the end without skipping, because you may feel like this video will be little lengthy, but it will be very well helpful for you for your preparation for the examinations. So once again, I request everyone who are watching for the video for the first time, kindly subscribe the channel and support us and share to your nursing friends. So without wasting time, we will move on to the first question in our series. And so you are watching the Nurse channel and the ACT series. Okay, so we will move on to the first question in this series. So this is the first question for you in this series. So the first question is from oncology, and the question is, which is the third most common site of metastasis? So the question is, which is the third most common site of metastasis? Okay, so you know that what is metastasis. So which is the third most common site of metastasis? That is a question, and your options are option number A, lung, option number B, liver, option number C, brain, and option number D, bone. So the question is regarding the third most common site of metastasis, not the first, not the second. So what is the answer? So the answer is option number D, that is bone. Okay, so if we will see the order of metastasis, the most common sites for cancers to metastasize include the lungs. So the lungs stands first, then comes the liver, then bones, and then the brain. Okay, so this is the order of metastasis according to the site. Okay, so the lungs comes first, then liver, then bone, and finally the brain. Okay, not finally, next the brain. So the other places include the adrenal gland, lymph node, skin, and other organs. Okay, so this is the order of common sites of cancers to metastasize. So definitely then you will have a doubt like, why lungs the most commonest site for the cancers to metastasize? So we will discuss now why lungs the most common site of metastasis. So we know that the pulmonary arteries are the most common route of metastasis. Okay, so the reason is very clear. The pulmonary arteries are the most common route of metastasis. And one more thing you should understand, that cancers most likely to metastasize to the lungs include those with a rich vascular supply draining directly into the systemic venous system. Okay, so from the tumor organ, from the primary tumor, that will be supplied by rich blood supply will be there, so that venous blood will be drained into the systemic venous system, that will be carried through the pulmonary arteries, and pulmonary arteries, you know the relation with the lungs, and like in that way the lungs are most common site of the metastasis. Okay, so everything will depends upon the vascularity of the primary tumor. Okay, so that's all regarding the first question. I think the first question itself is very important and very informative. Now we will move on to the second question in our series. The question is from cardiology, and the question is, cardiac tamponade is also known as. So it's a simple question, but at the same time it is a little confusing also. So cardiac tamponade is also known as dash. So the options for you are, the first option A, pericardial effusion, the second option pericardial tamponade, the third option pericarditis, and the final option cardiomyopathy. Okay, so what is cardiac tamponade? It's another name. So as I told in the beginning, it's a very simple question. So the answer is obviously the option number B, that is pericardial tamponade. So definitely you will have a doubt like, then what is the difference between pericardial effusion and pericardial tamponade? So that we will discuss in the explanation of this question. So first of all, I will explain what is cardiac tamponade. So the cardiac tamponade, also known as the pericardial tamponade, is the building up of fluid in the pericardium. Okay, that is pericardium. You know that there is a fibrous sac around the heart, and it is resulting in the compression of the heart. That is very, very important. So the fluid will be filling in the pericardium, and it will result in the compression of the heart. That is cardiac tamponade. So you know that what is pericardial effusion. Okay, so pericardial effusion also is a collection of fluid, right? So then what is the difference? Then how do cardiac tamponade and pericardial effusion differ? So what is the difference? What is the difference between cardiac tamponade and pericardial effusion? So we will see that the pericardial effusion is the accumulation of fluid in the pericardial space between the parietal and the visceral pericardium. Okay, so that is the accumulation. It is just an accumulation, means that is known as a pericardial effusion, and as a result there will occur the compression of the heart, especially the right ventricle, and can affect the cardiac functions, and that is known as the cardiac tamponade, and it is a life-threatening serious issue. Okay, so cardiac tamponade is a pathophysiological process thereby elevated intrapericardial pressures from a pericardial effusion causes compression of the heart, especially the right ventricle. Okay, so I think it is clear now. So if you see the pathophysiology, first there will be pericardial effusion, and as a result of the effusion, what will happen is the fluid will compress the heart itself, especially the right ventricle, and definitely that will affect the venous return and the other physiological processes. Okay, so that is the difference between pericardial effusion and cardiac tamponade. Okay, so we will see the other options also. We have given about the pericarditis. So what is pericarditis? Pericarditis is simply the inflammation of the pericardium. That is pericardium, you know that the fibrous sac surrounding the heart. And another option was cardiomyopathy. So cardiomyopathy don't have any relationship with this pericardial effusion and cardiac tamponade. So it is a group of disease that affects the heart muscle. Okay, so muscle. Okay, so regarding cardiomyopathy, we will add another important questions in our next series. Okay, so kindly keep in touch. So pericarditis is inflammation, cardiomyopathy is the disease of the muscles of the heart. Okay, so I think from this question you are getting information regarding cardiac tamponade and pericarditis and how it differ, and pericardial effusion and how it differ. Okay, so that's all about the second question regarding from the cardiovascular system. Now we will move on to the another important, very, very important question in this series. That is the third question: which drug toxicity can cause Xanthopsia? Okay, so what is Xanthopsia? You should understand first. Anyway, we will see the options for this question. So the options are: the first option is lithium, the second option is digoxin, the third option is magnesium, and the final option is acetaminophen. So which drug toxicity can result in Xanthopsia? Okay, so what is the answer? So first of all, definitely you should understand what is Xanthopsia. If you don't know what is Xanthopsia, you can't answer this question. So first of all, we will see the answer for this question. So the answer is digoxin. Okay, so the digoxin toxicity can result in Xanthopsia. And first of all, we will see what is Xanthopsia. So what is Xanthopsia? It is a form of chromatopsia, which means a visual abnormality in which the objects look as though they have been overpainted with an unnatural color. That means if you are seeing an object, then some unnatural color will be surrounding the object, like a halo we can see around the objects. Okay, so the halo sign can be seen in digoxin toxicity. So the development of such unnatural paint over an object is known as the Xanthopsia. So understood now what is Xanthopsia, and Xanthopsia can develop in digitalis toxicity. So we know that what is digitalis or the digoxin toxicity means. It is a type of poisoning that occurs in people who take too much of the medication digoxin. So I am not going in depth about the digitalis toxicity. Whatever related to the question I am explaining here. So the first symptoms of the digoxin toxicity are gastrointestinal symptoms like abdominal cramps will be there, vomiting will be there, diarrhea will be there, and visual disturbances. That means a green or yellow halos or the fuzzy shadows can be seen, like driving at night with dirty glasses. Okay, if you are driving the car with dirty glasses, we can see the halos or the fuzzy shadows. So the visual disturbances like green or yellow halos, like the xanthopias and fuzzy shadow, and other gastrointestinal issues like abdominal cramps, diarrhea, vomiting, all these things are the first symptoms of digitalis toxicity. So an additional information for you, the therapeutic range of the digoxin is 0.6 to 1.2 nanogram per ml. Okay, so its therapeutic range is 0.6 to 1.2 nanogram per ml. Okay, so xanthopia, digoxin toxicity, okay, these terms please keep in mind. Okay, So now we'll move on to the next question in our series, that is the fourth question, and the question is, dash is an inherited disorder that affects the connective tissue resulting in two long extremities. So the question is very simple. An inherited disorder that affects the connective tissue. So the disease should affect the connective tissue, and as a result the patient should be presented with two long extremities. So what is that syndrome called? Okay, so that is a question for you. So the options for you are, the first option number A, Down syndrome, option number B, Turner syndrome, option number C, Marfan syndrome, and the final option, Klinefelter syndrome. So connective tissue disorder, two long extremities. So just keep these two key points while answering this question. So definitely you can answer easily. You can omit so many options from this question, and the answer for this question is option number C, that is Marfan syndrome. Okay, Marfan syndrome is the answer for the question. So we will see what is a Marfan syndrome and what is the cardiovascular problems because of the Marfan syndrome. Okay, so Marfan syndrome, otherwise known as the MFS, is a rare multisystemic genetic disorder that affects the connective tissue. Okay, so those with the condition tend to be tall and thin with long arms, legs, fingers and toes. Okay, so Marfan system is a connective tissue disorder. It is a genetic disorder, systemic genetic disorder, and because of Marfan syndrome there will be tall and thin, the patient will be tall and thin, and there will be long arms, legs, that means extremities, fingers and toes. Okay, so we have to see the what is the clinical implication of this Marfan syndrome. The most serious complication involved in the heart and the aorta, with an increased risk for mitral valve prolapse and aortic aneurysms. Okay, there are chances of getting mitral valve prolapse and aortic aneurysms in Marfan syndrome. Okay, so that's all regarding the question Marfan syndrome. So now we will move on to the next question in our series, that is the fifth question, and the question is, the typical pattern of fever seen in patients with Hodgkins lymphoma is. So the question is very clear. The typical pattern of fever seen in patients with Hodgkins lymphoma. So there is a particular name for that fever, and your options are, the first option is intermittent fever, the second option relapsing fever, third option pale Epstein's fever, and the final option continuous fever. So what is the typical pattern of fever that can be seen in patients with Hodgkin's lymphoma? So what is the answer? So the answer is option number C, that is pale Epstein fever. Okay, so we will see what is the peculiarity of this pale Epstein fever. Okay, so this fever is a rarely seen condition which is noted in the patients with Hodgkin's lymphoma, in which the patient experiences fevers which cyclically increase then decrease. Okay, so this is the important point, the cyclical increase and then decrease. First it will increase, then it will decrease. Okay, so that cycle will continue for an average period of 1 or 2 weeks. Okay, so for an average period of 1 or 2 weeks, that cyclical increase and then decrease of the fever can happen in some patients with Hodgkin's lymphoma, which is termed as the pale Epstein fever. Okay, pale Epstein fever. Okay, so keep the term in your mind, and the other options what we have given in the question, that you know that the typical type of fever in typhoid is of the continuous type. So one of the options was continuous fever. So continuous fever is a characteristics of the typhoid fever in a step ladder fashion. That means the fever will first the fever will be increasing in a step ladder fashion. Okay, step ladder. Okay, that increase will be there, that will be stable for some time, then again another increase, then stable for some time, then another increase. Okay, so that is a step ladder continuous fever, which is a typical characteristics of fever in typhoid. Okay, so the another option was regarding the intermittent fever. So what is an intermittent fever? Intermittent fever is defined as the fever present only for several hours during the daytime. Okay, so the fever is only during the daytime and it will be there for several hours, and this pattern of fever can be seen in disease conditions like malaria, pyogenic infections, then tuberculosis, then schistosomiasis, lymphomas, leptospira, borrelia, kala azar, septicemia, etc. Okay, so this is intermittent fever. So intermittent fever can be seen in many conditions like malaria, pyogenic infections and septicemia, TB, schistosomiasis, kala azar, borrelia, lymphoma, leptospira, etc. Okay, so this is intermittent fever. And one more fever was there, that is a relapsing fever. So what is a relapsing fever? In which condition relapsing fever can happen? It is a bacterial infection that can cause recurring bouts of fever, headache, muscle and joint aches and nausea. Okay, and there are three types of relapsing fever is there. The first one is a tick-borne relaxing fever, otherwise known as TBRF. The second one is the louse-borne relapsing fever, that is the LBRF. And the third one is the Borrelia guillemette disease, otherwise known as the hard tick relapsing fever. Okay, hard tick relapsing fever. So this is just an additional information for you. So relapsing fever, it is related to the tick-borne. It's a tick-borne infection, bacterial infection that can cause the recurring bouts of fever, headache, nausea, joint pains and muscle pains. Okay, so that's all regarding the regarding that question. I think from this question you are getting so many information. Now we will move on to the next question in our series, that is the sixth question, and this is regarding the development of a rash. So the rash seen in the typhoid patients is referred to as. So it's a very simple question. Rash seen in typhoid patients is referred to as, and the options for you are option number A, tomato spots, the option number B, dewdrop spots, option number C, flame spots, and option number D, rose spots. So what is a peculiar rash which can be seen in typhoid patients? So what is the answer? So obviously the answer is option number D, that is rose spots. Okay, so we will see the some terms regarding the typhoid fever rash. Okay, so the explanation is the rash seen in the typhoid patient is referred to as rose spots because these are small pink spots can be seen that appear on the trunk and fade with the pressure. So if you apply pressure, these rashes will disappear. Okay, so that is a peculiarity of this rash, and it is pink in color. Pink spots can be seen in the body and especially in the trunk, and they disappear in 3 to 4 days. Okay, within 3 to 4 days it will subside. Okay, so moving on to the seventh question in our series. So this is another important, very important and very informative question for you. So for which of the following cancers is alcohol consumption not a risk factor? So the question, read very carefully. For which of the following cancers is alcohol consumption not a risk factor? So alcohol consumption is not a risk factor for which cancer? For the options what we have given here, and the options are A, breast cancer, option number B, laryngeal cancer, option number C, esophageal cancer, and the final option number D, pancreatic cancer. So among these cancers, for which cancer alcohol is not a risk factor? That is a question for you. So it's a very tricky question. So what is the answer? So the answer is option number D, pancreatic cancer. Okay, so we will see which all cancers alcohol consumption is a risk factor. So we know that alcohol consumption is associated with 7 types of cancers, which include oral cancer, pharyngeal cancer, laryngeal cancer, esophageal cancer, breast cancer, bowel cancers, and liver cancers. Okay, so these are the 7 cancers that can cause as a result of the alcohol consumption. So definitely you can raise a doubt like why alcohol consumption, how alcohol consumption can be a risk factor for these cancers. So that we will explain in the next point. So why alcohol is a risk factor? So we know that ethanol is a content of the alcohol is metabolized to acetaldehyde. Okay, ethanol will be metabolized in the body to acetaldehyde, which causes damaging DNA attacks. So what is DNA attack? DNA attack means some strands of the DNA that will bound to the chemical cancer chemical substances. Okay, so there will be a DNA attacks will occur, and it will result in and this is carcinogenic, and hence it is carcinogenic. Okay, so that is one reason. And in addition to that, the alcohol is a solvent that increases the absorption of cancer carcinogens, including those in the cigarette smoke. Okay, so whatever you know that tar and nicotine and tobacco, while we are smoking, these in that also carcinogenic substances will be there, and in our day-to-day life we will be exposed to so many carcinogenic substances. So if we are drinking alcohol, what will happen is this alcohol is a solvent that can increases the absorption of these chemical carcinogens and resulting in the development of cancers. Okay, these are the two reasons. So first one is the ethanol, and it will be metabolized into acetaldehyde, which in turn can cause the DNA attacks. So you should understand what is a DNA adduct. DNA adduct means DNA that will be bound, some strands of the DNA will be bound to the chemical carcinogens, okay, and then it will become carcinogenic. And the other reason is the absorption of the cancer carcinogens by the alcohol. Okay, so these are the two reasons. And we have seen breast cancer. So alcohol also increases the estrogen level. That is another thing, another third point. The alcohol will increases the estrogen levels in women, which they account for the higher rates of breast cancers in women who consumes alcohol. Okay, so that is a reason for increased chances of breast cancer for alcohol consuming women, because it will increases the estrogen level. Okay, I think this is a new, very good information for you. Now, very important information for you. Now we will move on to the 8th question in our series. The 8th question is a very important question, and the question is: the following are signs and symptoms manifested by a patient in the febrile phase of dengue fever, except. So the question is very clear. The following are signs and symptoms manifested by a patient in the febrile phase of dengue fever, except. So the options are what I am going to tell are the features which can be seen in a dengue patient in the febrile phase and which is not present. That is a question, and the options for you are: option number A, high fever; option number B, rash; option number C, petechiae; option number D, severe GI bleeding. So just think about the phases of dengue fever and what all clinical manifestations can be seen in each phases of dengue fever, and you can answer this question very easily. So what is the answer? Febrile phase of dengue fever. So definitely the answer is option number D, that is a severe GI bleeding. So we will see the phases, just a brief introduction to the phases of dengue infection. And the first phase is known as the febrile phase, and it usually lasts for about 2 to 7 days. So the febrile phase will be lasting for 2 to 7 days, and the patient will be presented with, these are the clinical manifestations that you have to understand. And the clinical manifestations during the febrile phase include sudden onset of high grade fever, which is accompanied by facial flushing, skin erythema, generalized body aches, myalgia, arthralgia, retroorbital eye pain, photophobia, and headache. And along with that, there will be GI symptoms like anorexia, nausea and vomiting. Then sore throat will be there, and infected pharynx will be there, and conjunctival infection also may be seen in some patients. Okay, so these are the features that can be seen in the febrile phase of dengue infection, which is usually lasting for 2 to 7 days of the infection. Okay, so now we will see the critical phase. The second phase is the critical phase. So the critical phase usually starts around the time of defervescence, that is between 3 to 8 days of the infection. Okay, so 2 to 7 days is the febrile phase, 3 to 8 is the critical phase, and during this time the patient will be presented with abdominal pain and tenderness, then persistent vomiting. Vomiting will be there in the first phase itself, but there will be persistent vomiting will be there. Then accumulation of clinical fluids like ascites will be there, pleural effusion will be there, then subcutaneous mucosal bleeding will be there, then lethargy, restlessness, there will be liver enlargement more than 2 cm, and there will be an increase in the hematocrit with a rapid decrease in the platelet count. There will be rapid decrease in the platelet count. So we know that the hematocrit, the decrease in the platelet count can also be seen during the critical phase of dengue fever. Okay, this can be another question for you. Okay, so we know that in dengue patients there will be marked decrease in the platelet count. So that can happen during the critical phase of dengue fever. I think it is clear for you now, and some more information I can share with you, and that is regarding the convalescent phase. So first is the febrile phase, second one is the critical phase, the third one is the convalescent phase, and the patient will report a sense of improved well-being and a return of appetite. There will be vitals will be stabilized, that will be widen pulse pressure will be there, strong palpable pulse will be there, that all things will be subsiding. Then the patient will have sometimes bradycardia, then hematocrit levels will return to normal. Then there will be an increase in the urine output, then appearance of the characteristic rash in the convalescent phase, and that means at the end of the disease we can see a particular rash in the patients, and it is a confluent, sometimes pruritic, erythematous or petechial rash with multiple small round islets of unaffected skin, described as isles of white in the sea of red. Okay, so this is the peculiar characteristics of the rash which can be seen in the dengue fever. That means in the normal skin will be seen as round, and the rashes will be seen among the rashes, the normal skin will be seen as a round like an island. Okay, so it is described as the isles of white in the sea of red. Okay, so this is associated with the dengue fever, which can be seen in the convalescent phase of dengue fever. Okay, so that's all about the clinical manifestations of the dengue fever. I have explained you in brief. You can go through in detail later, because it is very, very important in exam point of view also. Okay, I think that was a little lengthy, but it is very, very important. So now we will move on to the next question in our series. That is the 9th question, and the question is, which of the following should be obtained from a client prior to having electroconvulsive therapy? So what should be obtained from a patient before ECT, that is electroconvulsive therapy, among the options? Okay, so the options for you are, first one is a jaw x-ray, the second one is a pelvic x-ray, the third one is a chest x-ray, and the final one is a spinal x-ray. So which x-ray need to be taken before electroconvulsive therapy? That is a question for you. Which x-ray? So jaw, pelvic, chest or spinal? There's nothing to confuse in this question, to get confused. So only the answer is definitely option number C, that is chest x-ray. So why chest x-ray? You know that the side effects of the anesthetics which are used during the ECT includes the chest infections and the heart issues. Okay, so there are chances for aspiration and related complications, and patient can end up in pneumonia. So to protect against these complications, the patients have a full medical examinations and the routine blood test before the ECT is given. Okay, so they may ask for chest x-ray or heart racing like ECG and all, to check that their lungs and heart are healthy and are fit for ECT. So you know that before any ECT procedures we have to get the fitness from the anesthetist, and during the pre-anesthesia checkup we used to go for these investigations, the basic blood investigations, and definitely a chest x-ray and an minimum an ECG should be taken for evaluate whether the heart and the lungs are healthy or they can withstand the ECT. Okay, so that's all about the question. That was a simple question. Now we will move on to the 10th question in our series. So this is from the central nervous system, very important question. The pyramidal pathways cross over at the end of which of the following? So the question is the pyramidal pathways. Okay, we know that about the so many tracks. So the pyramidal pathways cross over at the end of which of the following? So the options are option number A, thalamus, option number B, pons, option number C, medulla, and final option number D, midbrain. So where the pyramidal pathways cross over? So pyramidal, from that name itself, if you think in detail about the pyramidal term, you can answer this question very easily. So the option number C is the answer for the question, the medulla. Okay, so you will see what is the pyramidal tracts where it is crossing over. So the majority fibers of the corticospinal tract cross over in the medulla oblongata, resulting in the muscles being controlled by the opposite side of the brain. So you know that there will be a crossover will happen. So if the left side of the brain is affected, then the manifestations can be seen in the right side. Okay, that is because these pyramidal tracts are getting crossed above the medulla oblongata. So I told you regarding the term pyramidal. The pyramidal tracts are named because they pass through the pyramids of the medulla oblongata. Okay, so they are passing through the pyramids of the medulla oblongata. So that's why it is named as the pyramidal tracts. Okay, so I think that question also is clear for you now. Now we will move on to the next question in our series, that is the 11th question. The question is here in the screen. What is the most common primary site of tumor in patients with multiple brain metastases? So the question is very clear, nothing. So to brain metastasis happened, so where is the primary tumor? So from which which primary tumor the main metastasis can occur commonly? So that is a question. Okay, so the primary site of tumor in patients with multiple brain metastasis. So which is the most common primary tumor that can metastasize into the brain stem, to the brain? So that is a question for you. So the options are, so this was a question which was asked before, it's a previous question which was asked in the ACT exam. So the options are option number A, breast cancer, option number B, colorectal cancer, option number C, lung cancer, and option number D, prostate cancer. So among this cancer, which cancer will metastasize to brain very fast? Very fast means very commonly. Okay, so I think this is the answer for this question was already explained in this session itself. So you can answer the question very easily. Our first question was related to the metastasis. So keep that in mind. Think about that question and answer this question very fast. So the answer is, you know that it is the lung cancer. Okay, so we know that lung cancer, already I have explained why lung cancers are getting so much fast spread to the other areas of the body. So the order of common primary tumors in the brain metastasis is first lungs. Okay, so the lung cancer can metastasize to the brain very easily. Then comes the breast cancers. Okay, then comes breast cancer. Then comes the genitourinary cancers. Then osteosarcomas, etc., etc. Okay, so a long list is there. Okay, so first lungs cancer. Lung cancer will be the primary tumor that can metastasize to the brain very fast. That is the most common primary tumor. Then breast cancers, then genitourinary cancers, osteosarcomas, etc. Okay, so that also is a very informative question for you. Now we will move on to the next question in our series. That is a 12th question. That is from the ear anatomy. Very easy question. Endolymph is formed in. Endolymph is formed in where? So the options are option number A, bony labyrinth, option number B, membranous labyrinth, option number C, ossicles, and option number D, tympanic cavity. So where you can find endolymph? So that is a question for you, and the answer is definitely option number B, that is a membranous labyrinth, not the bony labyrinth. So now we will see that the endolymph, it is a fluid contained in the membranous labyrinth of the inner ear, and its function is hearing and balance. Okay, I am not going in depth into the topic, and if you want to get in detailed information, you can go through our previous videos, and their ear anatomy, everything is explained. Okay, so endolymph is the fluid which is contained in the membranous labyrinth of the inner ear, and its main function are hearing and balance. So now we will move on to a picture based question, and this is also very important. I think you can identify the picture that I have shown in the screen right now. This instrument is used to visualize. Okay, so I have given you an instrument here. This is a picture of an instrument, and this instrument is used to visualize dash. So what is this instrument? That you have to keep in mind first. So the options for you are ear, eye, nose, throat. Ear, eye, nose, throat. So what is the instrument? So this is an ophthalmoscope. So definitely the answer is eye. Okay, so the picture is a picture of the ophthalmoscope, and it is used to visualize the fundus of the eye. So that's why it's also known as the fundoscopy. Okay, ophthalmoscopy, also called as a fundoscopy. It is a test that allows a health professional to see inside the fundus of the eye and other structures using an ophthalmoscope. So the instrument what I have shown in the screen is ophthalmoscope. I think you identified it. Okay, that's all regarding the picture question. Then now we will move on to the second last question, and it is a slightly confusing question but very easy question. Untreated thyrotoxicosis can lead to. So the question is regarding the thyroid. So untreated thyrotoxicosis can lead to. Thyrotoxicosis, if it is untreated, it can lead to. That is a question, and the options are option number A, hyperthyroidism, option number B, hypothyroidism, option number C, thyroid storm, option number D, hyperparathyroidism. So what is the answer? Is it confusing? Hyperthyroidism, hypothyroidism, thyroid storm, hyperparathyroidism. Very easy question. Thyrotoxicosis can lead to dash. That is option number, answer is option number C, that is thyroid storm. Okay, thyroid storm is the answer. So we will see each one in brief. What is hyperthyroidism? So hyperthyroidism means it is the condition that occurs due to the excess production of thyroid hormones by the thyroid gland. Okay, very simple. Excess production of thyroid hormone in thyroid gland. So what is thyrotoxicosis? Thyrotoxicosis is the condition that occurs due to excessive thyroid hormone of any cause. Okay, that is important, for any cause, and therefore it includes the hyperthyroidism also. Okay, so thyrotoxicosis is a hyperactive thyroid. Okay, hyperthyroidism, then thyrotoxicosis. I think these two terms are clear for you now. Now we will move on to the next term, that is the thyroid storm. What was the question we have asked? So the thyroid storm, otherwise known as the thyrotoxic crisis, is a very rare but life-threatening condition of the thyroid gland that develops in case of untreated thyrotoxicosis. That is, if hyperthyroidism or thyrotoxicosis or the if you are not treating the thyrotoxicosis, it can lead to what? Thyroid storm or thyrotoxic crisis. Okay, so that's all regarding the question. Now we will move on to the last question in our series, that is the 15th question. This is regarding a tumor biomarker. So which serum tumor marker is most helpful in establishing a diagnosis of choriocarcinoma? Okay, so which tumor marker is most helpful in establishing a diagnosis of choriocarcinoma? Choriocarcinoma. Regarding choriocarcinoma, I have explained in the previous session of our SCT series. So whoever didn't watch the video, kindly watch it, and okay, then you can answer this question very fast. Okay, so the options are alpha fetoprotein, option number B, carcinoembryonic antigen, option number C, CA125, and option number D, human chorionic gonadotropin. Okay, HCG. So which is the serum tumor marker which can be used for the diagnosis of choriocarcinoma? The last question. So the answer is option number D, human chorionic gonadotropin, HCG. Okay, so that we will see now. And before that, this regarding this alpha fetoprotein, carcinoembryonic antigen, these two things I have explained in the previous video. So once again, I request everyone who didn't watch the videos yet, kindly go through those videos and you will get information regarding these biomarkers like alpha fetoprotein and carcinoembryonic antigen. Okay, so the answer for our question now is, that is a diagnostic tumor marker in choriocarcinoma is the HCG, that is human chorionic gonadotropin, and it is the ultimate ideal tumor marker for the gestational trophoblastic diseases. Okay, GTD, gestational trophoblastic diseases. And one more option was there, that is the CA125. So that is a ovarian cancer related tumor. Okay, this is an ovarian cancer related tumor marker, that is the CA125. The other options already I have explained in the previous session. Okay, so I think with that we are coming to the end of this session. So I thank everyone who watched the video till the end. So as I told in the beginning, for each question the explanations are very, very important. So kindly share to your nursing friends so that they are also getting a chance to utilize this platform. So once again, thank you for watching the video till the end, and kindly keep in touch with us, and we will upload the next series of questions very shortly. So till that time, see you. Bye.